The hardest part, I think, of my job is getting the parents ready for that first exam and the potential to have surgery that same day. Because often we try to limit the exposure to anesthesia. So I do the best I can getting a feel for the child in the office, and then when I go to the operating room, I'll do about a 20-minute examination. The child will still be asleep. I will go talk to the parents, and I've had a pretty lengthy discussion already with them, and I've probably prepared them for the idea of surgery. And if I come out and say they don't need it, fantastic, this is not glaucoma, but often it is glaucoma, and I go out, I have a quick conversation, and then I have to operate on the child that same day, often on one eye or even potentially both eyes. So the key is having a good dialogue with the parents beforehand and preparing them for what's going on. So often I tell them that, this is something that we have to do, because if left untreated, this will result in permanent blindness. So I think though the parents are a little apprehensive at first, they understand that this is something that has to be done. They can see it. They can see their child is not doing well. Where we get into a little more challenging situation is after you've done surgery and you tell the parents, hopefully, that you've been successful, how often do you have to bring them back to the operating room for follow-up examinations? We do our best to limit how many times we have to do this, because there are risks associated with more anesthesia. With the advent of the eye care, which is a new device for measuring pressure, we're often able to check pressures more accurately in the office, but we still need to do an exam in the operating room every 3 to 6 months to make sure that we're following all our proper parameters. Even after you're done with the initial surgery, even if you have a good outcome, this is still a disease that needs to be monitored. So establishing a good relationship with the parents and having them understand what you're doing is very important. So pediatric glaucoma is one of the more rare conditions, and many people who do it because they enjoy it, and there is a little bit of learning on the job, which is the truth. So you will not go to a fellowship often and have tons of exposure to this disease process, because it is a rather rare disease. I was fortunate in where I trained that I learned how to do this procedure from Elizabeth Hodap, who's one of the best pediatric glaucoma specialists in the world. It is one of those conditions where sometimes the parents have to do some extra work in terms of getting their child to an academic center. So typically this specialists that are there are at one of the bigger hospitals. Because of the mechanism behind the development of the condition, it is often surgical. Medical management really does not take care of pure congenital glaucoma. There are some secondary glaucomas which can be managed with medicine, but often this is a surgical approach because there is some blockage of the drainage canal, and we really have to establish normal outflow. I think the future is trying to perfect the current surgery that we are doing, and we have seen great advances. So the surgery that I do for it is really just a slightly new twist on a very old surgery. So trabeculotomy has been around for decades, and it was originally done with what we call Harm's trabeculotome, which is a sort of a long blunted instrument in which you get into the canal and you open up the canal manually. With the new iScience catheter, we have a microcatheter with an illuminated tip. And the nice thing about that is that you're entering this very small canal called Schlemm's canal, and you're entering somewhat, and you're threading the catheter somewhat blindly. But what's nice is if you turn the illumination down on the microscope, the illuminated tip you can see to ensure that you're in the proper place as you're threading this canal 360 degrees. In the past, people would try to use a suture or other means to actually stent the canal and thread the catheter. With this new illuminated catheter, we're able to actually ensure that we're in the proper place and ensure that we get the entire canal treated, which I prefer, because that way if the child does need more surgery, I know I've exhausted my entire option. In the past, people did and still do goniotomies and Harm's trabeculotomies where you're treating part of the canal at a time. One of the nice things about the approach we use is that we treat the entire 360 degrees. So we are getting better at this type of surgery, but because it is a rare surgery, it is not one of those surgeries where there's a lot of people learning how to do new methods and learning how to do new things. But we have a very good surgery that works, and I think the more you do it, the better you get at it and the better outcomes we see.